Today's talk is entitled MitraClip, What if the Pentagon Built a $30,000 Clothespin? The history, indications, workup, and future directions of this particular technology. It's going to be presented to us by Dr. Sohrab Lutchmedial. Sohrab is not only a great interventional cardiologist and head of the cath lab, but he's also a leader in the area of MitraClip at our center. And obviously all of our consults for MitraClip funnel through Sohrab, as well as one of our surgical colleagues, Dr. J.F. Legare. And last but not least, Sohrab's a good friend and a great speaker. So I thank you for taking the time to do this, and I'll pass the mantle over to you.
Okay, thanks, Ansar. I appreciate that, and I hope I can be as engaging a speaker online, because I tend to wander around and use my hands a bunch. So I'm going to lose a bit of that with this. But Ansar and the surgical team asked me to speak about MitraClip. It's an area that we've been engaged in now at the Heart Centre over the past 3 years with increasing success. And it's an area that we're working very closely with our colleagues in the heart team with surgery and anesthesia and general cardiology towards the betterment of our patient. So we labeled it, what if we built a $30,000 clothespin? Because that's what we compare the MitraClip to. And let's talk a little bit about our device. So a bit of background, and this is fairly well-known news to everyone here. Mitral regurgitation, it's present in at least 1 to 2% of the population in general, 7 to 10% of patients over the age of 65, and increasing as we get older, and in many patients with congestive heart failure. Many people with severe mitral regurgitation, however, are excluded from surgery because of an increased perioperative risk. And many people with severe MR, of course, these comorbidities and that cause their increased perioperative risk are because the MR is not the main issue. The main issue is the ventricle or the myocardium. And some of these comorbidities, like depressed ejection fraction, can result in perioperative mortalities up to 11 to 12%, and even higher if you look at 30-day and 1-year survival rates. So what are we currently able to do for these people with mitral regurg? Medical therapy, there are a number of new agents, Ivabradine and Entresto, spironolactone, an old drug that is being used with success. We know that biventricular resynchronization therapy with our electrophysiology colleagues can help with heart failure symptoms. And we, of course, know that there's a strong place for surgical therapy for significant mitral regurgitation. So where does interventional cardiology and MitraClip fit with surgery and medical therapy for MR? Classification, we have to look at the classification just to understand that there are some very basic differences. We talk about primary or degenerative MR as being a problem with the valve itself, the tissue of the valve. It has an abnormality. Generally, it's a problem with floppiness and increased tissue size, resulting in billowing and regurgitation. But that's primary MR, structural abnormality of the valve leaflets or the chordae. Secondary MR is a much more difficult problem, and that's when the regurgitation is due to LV dilation, and that then will result in valve dysfunction, not only by increasing the size of the annulus, but also by pulling the chordae down apically, laterally, pulling the leaflets apart and resulting in further insufficiency. So functional MR is a big problem. This is a table that looks at where surgery really fits in to MR. And answer just a quick question. They can see my mouse, I think, when we're presenting?
Yes, they can.
So, perfect. So primary MR here, when we have significant or severe MR is defined by regurgitant fractions, that is the volume of blood that blows back into the left atrium, each ventricular contraction, not moving forward, but backwards into the atrium, greater than 50%, an effective regurgitant orifice area, or basically the size of the effective hole blowing back into the left atrium of greater than 0.4 centimeters squared, and LV dilation. These are things that define severe mitral regurgitation. And if you're symptomatic, mitral valve surgery ideally repair, but surgery or replacement is definitely indicated and beneficial for patients. If you have a good ejection fraction, it is absolutely a class 1 indication, but if you have a bad ejection fraction, well, we still should probably offer it to patients who are surgical candidates, but it may not be as slam dunk procedure, and the patients may not benefit quite as much. So symptomatic is simple for severe MR. Asymptomatic, a little more difficult. There's generally felt to be benefit if your ventricle is starting to dilate or if you're getting more problems with MR, atrial fibrillation or pulmonary hypertension. So that makes sense. Again, surgery for patients who can have surgery should be our method of therapy. And the issue now really comes up with secondary MR, and here's where surgery for even the symptomatic patients with severe MR, even as defined by our the numbers that I told you before, this is where surgical intervention has not been shown to be as beneficial. And this is, I think, this is our window here where MitraClip really starts stepping in and providing some benefit for our patients. So MitraClip has been developed really. First in man was back in 2003. So that's an awfully long time ago. And it's taken quite some time for it to really hit prime time. The original studies, first in man, were done in 2003. And the first major randomized controlled trial was called the Everest trial, Everest 2. And that was, we'll discuss that in one more slide, basically looking at primary MR, primary mitral regurgitation, and its comparison of surgery versus MitraClip. But now we have to skip all the way forward to now the most recent studies that have come out, the COAP trial, which finally looked at secondary MR, functional MR, and showing benefit here. And that was all the way back in now, 2018. So 15 years later, it's taken quite some time for this technology to spread. In the in-between, these were the Wild West days where interventional cardiologists were using MitraClip for secondary MR left and right, but not really knowing if there was a benefit. So it's only in the last year and a half, really, that we have a good authorization to move ahead with MitraClip for secondary. Here's the first study, though, that looked at surgery versus MitraClip, Everest 2. And that study was only 280 patients. Again, 70% of them were primary MR, so valvular structural abnormalities. And if you look at this particular study, they looked at an endpoint of freedom from death, from needing more surgery. And in the end, surgery was better. There was a lot of need for surgery after a MitraClip, 20% versus only 2% redo surgery. So in the end, surgery was shown to be more effective than MitraClip for these primary patients. However, in the year's time, the patients were both doing just as well. So quality of life and functional capacity, et cetera, was the same between the two groups, but surgery did technically certainly seem to be better. Nonetheless, this let MitraClip get a CE mark across the world, and it is now was then being used for all types of MR. This is what the clip looks like, and this is why we call it a clothespin. These arms and these grippers, between the arms and grippers is where you grab that mitral tissue. And it's on top of this long device. If anyone is up on the 3rd floor, I left one of the devices up there for them to take a look at, take it out of the box, take a look at it. And sorry, I'm charging you $30,000 for this talk because I opened up a whole box for it. But hopefully some people can actually benefit from physically looking at what the clip is. This is a picture of the actual clip going after a mitral valve, and we'll show how it works in some actual animations in a few seconds. So here, the MitraClip facilitates the reconstruction of an insufficient valve basically by pulling the leaflets together, the posterior and anterior leaflets together, and it creates a tissue bridge. This is a picture. Underneath this is a MitraClip. That's a pig model, but underneath this is a MitraClip, and you've actually pulled the two leaflets together and they fuse together, leaving now 2 neo orifices, which will not hopefully regurgitate as much, creating that tissue bridge. So the MitraClip, and this is what the COAP study has shown, and we'll discuss it. The COAP study for secondary prevention has improved survival, reduced hospitalizations, and improves quality of life. So let's talk about how and why that's done. Everest study, that was the original primary study. Yes, we did reduce MR, but again, those patients needed a lot of repeat procedures. In the COAP trial, we did not need as many repeat procedures, and that's because I think it was 15 years later and we had a lot more experience. Here's a picture of us. These are some intra procedure echoes. Right now, our anesthesia colleagues are doing a terrific job supporting us during the procedure, these patients under GA. Here, we're tenting and crossing from the right atrium into the left atrium with a Brockenborough needle and passing through transeptally. We pass from a large bore venous catheter from the right atrium and venous circuit into the left atrial circuit. When we cross, we then need to make sure that our catheter tips and our catheter device is high enough in the left atrium that we can push the device across into left atrium and then angle it 90 degrees down perpendicular into the left ventricle and across the mitral valve. We need about 4 centimeters to do that. So we need a large enough atrial septum and a good enough crossing in order to be able to do that. Once we are able to pass the device into the left atrium, this is an image here showing this is what the MitraClip looks like as it's positioned above the mitral leaflets. It's not at a great angle here. We're trying to get it a bit more perpendicular, different angle, LVOT type angle here. It looks a little more perpendicular in the AP zone, but we're trying to optimize basically the angle of entry into the left ventricle. If we go in at a bad angle, we're going to end up grabbing a lot of these, which are chordae. And if we actually do grab chordae and then we pull our MitraClip closed, we're going to be actually distorting the leaflets themselves and possibly causing more MR than we started with. So it's really important for us to come in really nice, boom, perpendicularly, and avoid grabbing chordae if at all possible. Once we're able to do that, here's a set of images showing the MitraClip as it is crossing into the left ventricle. We're trying to aim for the jet of MR. And we're doing this using generally X-plane, like 2 different images of our intracardiac ultrasound, or sorry, of our transesophageal ultrasound. And we're aiming to pass that clip. And these are the 2 wings of the clip as we then push it open. So we open up the wings of the clip, then push it into the left ventricle. Next step is then fishing. And this is an image of us actually trying to fish. This is the MitraClip open underneath the valve. And we're positioning ourselves here, posterior leaflet, anterior leaflet flopping here. And over the next 30 seconds or so, we're slowly trying to pull our device upwards, pull it upwards, make sure that we're grabbing the posterior and anterior leaflets together at the same time. The newer devices actually allow us to close one arm first, and then we can actually shift the whole device and pull it closed, pull closed on a second leaflet at a second time. So the newer devices are even more elegant. But here we're already starting to now trap here the anterior leaflet closely. You saw the little, I'm not sure if you saw the little grippers come down, but the grippers are now that bright line here. Grippers are coming down and we're closing the arms and we're actually now trapping that anterior leaflet with the posterior leaflet. So this is how we grab. And this is that's the part actually that's the most fun going fishing, but it's the preparation that takes a good hour and a half to get us in place. And then once that's all done, it's a matter of actually releasing all the cords and cables and releasing the device. And this is what the MitraClip will look like on a plain chest x-ray once it's all said and done, floating on the mitral leaflets. So that's what the procedure looks like, but who are the people that we want to be targeting? We already know that, again, primary MR is really, I think, a disease that should be addressed and identified by our surgical colleagues initially. If that patient for primary MR is not a good candidate for surgery, that would be an excellent consultation referral to us for MitraClip. However, for secondary MR, these are the criteria for the COAP trial. And the COAP trial here, we're looking for patients that had a reasonable EF, but we didn't want a blown out ventricle. We did not want a dilated ventricle. We wanted severe MR, significant symptoms despite optimal medical therapy. And moving from there, they wanted these patients to actually still have hospitalizations despite this medical therapy. So they needed to be symptomatic despite the fact they were being treated well. They needed to be assessed by a heart team. We didn't want them to be in shock or need revascularization or have bad COPD or bad pulmonary hypertension. So again, these are patients that probably might get deferred either back to the surgeon or to plain old medical therapy if we can. This is an important criteria. If their mitral valve area was less than 4 centimeters, that generally meant that if we actually put a MitraClip in, we could make that mitral valve area even smaller and induce significant mitral stenosis. So these are patients that we couldn't really enroll either. So once they did look at this trial, they looked at hospitalizations as their primary endpoint, and that is important, but I think the more key endpoint is the mortality. They got 1,500 patients. That was after screening closer to 10,000 patients, really. So it was a smaller number that got into the trial. And of them, 300 got MitraClip and 300 got medical therapy or so. Here's the bottom line. Primary effectiveness, we reduced hospitalizations. That's important to the patient. That's important to their quality of life. But also equally important to the rest of us was the reduction in mortality. So again, for secondary mitral regurgitation, where surgery has not been shown to have a benefit and medical therapy is of limited benefit as well, we were able to reduce mortality at 2 years from 46% down to 30%, which is a significant improvement. This trial, the COAPT trial, came out a few months after another MitraClip trial called MitraFR. MitraFR was negative, COAPT was positive. Some of you may have heard of MitraFR. Big differences between the two trials. It was really all about study design. MitraFR had patients that had smaller regurgitant areas. They had bigger left ventricles, 135 versus 101. These were patients with more ventricular problems. The ventricle was more of an issue here than in COAPT, where the mitral valve was perhaps more of an issue. And they had no guideline indications for medical therapy in MitraFR either. So I think it was a different patient population, different criteria for inclusion, different follow-up and therapy. And they also had a lot more procedural complications in this European trial too. So a number of reasons why MitraFR, I think, it shouldn't be discounted. I think the important lesson from comparing these two trials is COAPT was well run and the patients were well managed. We do not want to degenerate into the free-for-all that is MitraFR follow-up. I think I only have another minute or two left, but these are the things that successfully tell us how we're going to be successful with MitraClip. The MR ideally central. We don't want the valves to be calcified. Valve area is fairly large. We want the posterior leaflet to be long enough to grab. We don't want the gap between the leaflets to be greater than 1 centimeter, and we do want the leaflet still to be able to be coapting to a reasonable level distance from the annulus and touching together. So these are things that we look at during the echo to tell us whether or not we think we're going to be successful with the MitraClip. Skipping that, this is our current practice. We have the patients clinically evaluated by general cardiology and our echocardiography experts, by interventional cardiology, by surgery and anesthesia as part of the heart team. We do give them a functional and neurocognitive assessment. We try and assess that they are actually on proper guideline-derived medical therapy, and we give them an electrophysiology consult for CRT if needed. We then ideally do a transesophageal echo at our own center, but other centers have been doing an excellent job of late. They've gotten all the needed views to give us excellent imaging. Ideally 3D, but any good transesophageal echo with specific MitraClip views help us. And then we cath the patient, and then we discuss them at our rounds. So it's a multi-step process that we're really trying to mirror the COAPT evaluation. So that is what we're currently doing at our center. Here's a couple images of what's actually being done in some other centers. If you're wondering, the mitral valve is such a complex device that there are actually other ways that people are tackling it. This is one way that they're introducing this, this odd wire-like device into the coronary sinus, and you can cinch this to this together and actually close up the mitral annulus by the coronary sinus. So that's one method that's being tested. Another method is actually something that's also going through the arterial access through the left ventricle. You retroflex a catheter and actually pull it up underneath the mitral valve and then do an annuloplasty underneath the mitral leaflets and chordae themselves too. So there's some very complex looking techniques that are looking at different ways to approximate the annulus together that are being tested at other centers. Here's a large table of all the different devices that are being used at centers across the world to see whether or not we can actually do a better job even than MitraClip. But currently, MitraClip is the only device that is authorized for use, certainly in Canada. And we're now future directions here at our heart center, looking at expanding our MitraClip practice. It is an expensive device, so we have to be cognizant of that. And we're not trying to ration it, but we're simply trying to, at this point, use it for the most appropriate patients. But there will come a time where we may look at using the clips themselves for tricuspid clipping and avoiding complicated and difficult tricuspid surgeries. We may start looking at straight up mitral valve percutaneous implantation of new valves, which may be the easiest second solution. And we're going to be hopefully doing this in our hybrid room in the, I call it near future, perhaps the next 2 to 3 years. So those are our future directions. And that is the end of our end of my talk, just under 25 minutes. Hopefully I have a bit of time left for questions at this point as to where we're going or about anything about our current practice.
Great. Thank you, Sohrab. That was excellent. Very much appreciate that overview. Obviously, it's a big subject, and you covered a lot of ground in a short period of time. I just wanted to, I guess, share some of the questions that came through the chat line. The first question is from JF. How long should a patient be on optimal medical therapy before they're considered for a clip?
So I'd say a minimum of 3 months. And in the co-op trial, they were actually assessing these patients sequentially. There were some patients that were only entered into the trial 9 to 12 months after they started initiating therapy. And of course, to properly answer your question, it's not just after initiation of therapies, but after full optimization of the doses. So max dose Entresto, maximum dose spironolactone, and then assess for, I think 3 months on those maximal doses to see if patients are doing better. Again, this is a complicated therapy, and I don't think we need to rush patients into what they think is a mechanical solution for what is really a multifactorial problem, especially for our secondary MR patients.
The next question is from Sharif in Moncton. It said most of the data is on people with LV dysfunctional and functional MR, but what if you have a patient with a normal ejection fraction, but who still has significant mitral regurgitation, for instance, as a result of posterior leaflet restriction from MI or prolapse? If they're not a surgical candidate for whatever reason, are we considering the clip in these patients?
Yeah, I think, yes, we are. And the data there, amazingly enough, even though that was the original trial, the Everest trial, looking at patients with, primary valvular issues and primary MR, the data there showed that patients did have an improved quality of life, those that got MitraClip. They simply had a higher frequency of needing reoperations or operations after the MitraClip. And that was early in the experience. That was in 2003. And I think if you redid that study now, you probably wouldn't have as many technical issues with the MitraClip itself. So if that patient is not a surgical candidate, I absolutely think that they would be excellent candidates for MitraClip. Quite frankly, it's easier to identify an abnormal valve leaflet and target it with a MitraClip than it is to go after secondary MR. So technically, I'd be happy to see those patients on the table as well.
And a good question, I think, also revolves around, this is from Ashley. Obviously this technology is evolving and it continues to improve. And I think even in the 3 years that we started the program, I've probably started to see improvements in both the delivery systems, but as well, I think just in terms of the heart team model and getting everyone's input, and that's probably improved outcomes. But I guess the question is really just sort of on cost-benefit analysis, and it's hard to make that assessment now because it's early. It is an expensive device, and we don't really have good long-term data. But is there anything out there in centers that have been doing this for quite a while that looks at, the balance between the expense of the device against, required or readmissions for heart failure, requirements for repeat interventions?
So there are evaluations looking at the COAP data, and it is still an expensive device to use, even when you adjust it as quality years of life that are improved. We're talking still over $60,000 to $70,000. But if we're looking at mortality, I think we'd be happy to spend $70,000 to $80,000. If we're just looking at morbidity, it is definitely not as attractive a device. We're reducing hospitalizations and improving quality of life, but many of these patients nonetheless deteriorate because of their ventricular issues nonetheless. So I know that we have to be cognizant of cost, and the device is actually ramping up from now $30,000 to $35,000 with the latest iteration. So again, that's why I think the heart team model is important, to make sure that we've covered every base before we end up resorting to the MitraClip. We have no budget for it in the province. We have no budget for it in the Heart Centre. We're using money that much like we're doing for TAVI, we have only a small budget for that. We're simply doing the best job for our patients and using our budget as we see fit to. I think we should probably be petitioning the province for money and mirroring what they're doing in Ontario. So in Ontario, they have shown some cost benefit analysis for doing this versus pure medical therapy alone. And probably we should be trying to follow Ontario's lead in that regard and getting better funding for the clip independently of other devices and procedures.
So a last question, I guess, the referral process for MitraClip. Dr. White posed that, and I think this is an appropriate question not only for ourselves at the Heart Centre, but also for cardiologists and internists from across the province who may be interested. And it, probably very much mirrors the TAVI process and how we kind of have allowed that to evolve over time. What would you say to somebody who's interested in referring a patient for the MitraClip? What should they be doing?
So I think it would be ideal if that referring specialist could have tried to identify all the possible guideline-derived medical therapies that are appropriate and have at least tried to institute them themselves first, or have a good rationale why they may not be appropriate. So, have tried Entresto, have tried spironolactone, and so gone through that process. Ideally, they should ensure that the patient is truly symptomatic and not, we're not going to be accepting patients that are asymptomatic but with severe MR at this point in time for the secondary causes, unless we think there's a true mortality benefit, i.e. they're a younger patient that is completely asymptomatic. So I think a little bit of culling, bit of weeding out by referring specialists, putting them on the optimal therapy first and then referring them to us would be ideal. Getting a transesophageal echo at their home center would save time as long as that transesophageal echo is done with specific MitraClip views in mind. And I can provide those needed views to anyone that requests them. And I think we've sent them out to everyone in Fredericton and Moncton, which has been the predominant source of our referrals. And then, quite honestly, I would refer them to a surgeon first, a surgeon like JF and myself concurrently, because that way we can give a first quick screen before we put them through the whole process. So that would be, I think, the ideal sort of referral pattern or flow for those patients.
Excellent.
That answers.
Yeah, that's great.
JF asked, how do they tolerate the procedure? So far, we've had an amazing results with our patients. All of them have left either the day following or 2 days following the MitraClip itself with no significant peri-procedural complications in terms of access or stroke or other major complications. So thus far, these patients are really tolerating it quite well. When you get to longer procedures, I think one of the major issues might be actually esophageal because they've had the probe in for so long.
Yeah. All right. Well, Sohrab, on that note, thank you so much for your time and for an excellent presentation. And thank you, everyone, for an excellent discussion. I will be sending out the recording for this, at least a link to the recording for this in the next few days, as well as a notification for next week's rounds. Once again, thank you, everyone, and have a great day, and stay safe.